the end of the conference. We are having a communication problem with our colleague Abdullah Osman in Saudi Arabia. We try to use the university teleconferencing system, but they have a problem with the IP address. They are using a local IP address in the Al Qura University and not communicating. We can see him, but we cannot communicate with him. It will be difficult to be one-way communication. We tried to use the Sky, and again we failed because there is a problem with the communication. I'm not sure from his side as well. So we're going to leave his presentation till the end of the session. We have his PowerPoint presentation. Wendy can talk about this. Oh dear. We have a 25 slide, but because they were together and they notice happening there. We will wait until the end of the presentation session, and then we'll see if we can communicate or not. We're going to start with the diagnostic part, the imaging diagnostic part of the session, and Paul kindly will going to start the session, please.
Right. So, as Professor Fahal mentioned, welcome to the fourth session about diagnostics of mycetoma. Hopefully we'll be able to contact Saudi Arabia later for our Skype communication. And I'd like to hand over to Dr. Mustafa El Raya, who's going to tell us about ultrasound of mycetoma. Okay, thank you.
Assalamu alaikum. I'm going to talk about role of ultrasound in diagnosis of mycetoma. Here we have rich material of patients, so all these patients were scanned here. And ultrasound is a safe, non-invasive procedure, and the cost is the least for the diagnosis. So why we do ultrasound for mycetoma? If this question may be raised, first to diagnose mycetoma. But although many patients may present with discharging grains, so this is pathognomonic of mycetoma. But also some lesions are closed, so we need to explore this nature of the swelling. Second, to rule out similar lesions and to locate the site of the lesion in relation to other structures. And also it is very important to use ultrasound in the measurements of the dimensions of the lesion, so we can know what size of the lesion and the site of the lesion in relation to for example, tendons and muscles. This is very important in planning surgical removal of this mycetomatous lesion. And some lesions may not be seen or palpated, so we want to know the number of underneath lesion and communicating pockets, so we know the number of pockets and maybe communicating with each others. And also it is very important in follow-up of lesions after surgical excision or medical treatment, if we want to see the progression of treatment, whether it is successful or static lesion or maybe no response to medical treatment. Also, if a material, local injection of a safe material can be guided also by using ultrasound. So we can accurately place the therapy into the pocket of mycetoma. But which material? This is an area of research. So ultrasound helps in identifying mycetoma from other similar conditions like foreign bodies, thorn granuloma, tuberculous abscess, because this is going for a long time, and neurofibroma. Other similar lesions, fibrolipoma, Baker's cyst and joint diffusion, especially in chronic arthritis, ganglion cyst, cellulitis, although this is an acute condition, but also we may have secondary infection in mycetomatous lesion. Kabusi sarcoma may simulate mycetomatous lesion, and malignant melanoma. So we are in need of ultrasound to differentiate these lesions from mycetoma. Mainly we have two types of mycetoma here, eumycetoma and actinomycetoma. And the ultrasound differentiation between the two types also can be as follows, as in this table. In eumycetoma, we have sharp hyperreflective echoes, while fine hyperreflective echoes also found in actinomycetoma. Floating apart from each other in eumycetoma, and sometimes demonstration of free grains moving on real-time scanning if we can do gentle squeeze with ultrasound probe. But in actinomycetoma, closely aggregated and settle at the bottom of the cavities. This is the general appearance of mycetoma. Here we have mycetoma pocket, and this is a grain, and this is Achilles tendon. So this was found in the pre-Achilles bursa. This is a bursa, and it is deep to the Achilles tendon. And you can see here the grain, the black one, and surrounded by small amount of fluid. Another pocket here, and you can see the grain here, hyper-reflective and well-defined. This is a bigger lesion, and we can measure the size of the grain here, and it is well defined in eumycetoma and measures about 2 millimeters in diameter, unless they aggregate, may form a large ball like this one. These are aggregates of small grains. So again, this is an eumycetoma. Here it was 2.7 millimeters in diameter. These are multiple eumycetoma, and also we have compacted grains here. These are two pockets. This is one pocket with another neighboring pocket. This is more superficial and this is deeper. Maybe some communication somewhere between these two pockets. So we can see a link between these two pockets. So these are communicating pockets. So these are two. Surgical excision should include the whole area. And as we notice, this is more superficial because this is the skin. So it is a superficial pocket. I don't know, sometimes we may I don't know why, but sometimes we may find small pockets communicating with each other. But sometimes it is very localized. So when a single grain is left, this may lead to recurrence again. So diffuse pattern of involvement also, it is noticed here in mycetoma, EU mycetoma. Again, this is more diffuse. It is not well defined as we saw in previous example. And this is a discharging sinus. This is the skin here. The skin was, surface here was breached, and there is discharge of grains through this sinus. So this is a pocket, and this is always giving black grains in EU mycetoma. Another one, you can see the sinus tract, and there is a grain here near the sinus tract, but this is communicating with a deep pocket here. Another pocket, small pocket here, just resting on the tendon fibers. These are the tendon fibers, and you can see the pocket just resting above the tendon. So deep excision is needed to eradicate this type of involvement. You can see here the deep grain. Sometimes only you may see one grain. And this is a sinus. In red Madura, we notice that there are very sharp and tiny grains, just 1 millimeter, and it looks like miliary shadows. So this is especially we notice this in red Madura. And as you can see here, this is a bone surface. The bone surface here is irregular, and it starts to invade this bone. So this periosteum, this is periosteal reaction. As you can see, thickening here and irregular bone surface. Another EU mycetoma with discharging sinus and irregular, but we can locate and map the area of involvement. Similar example of EU mycetoma. This is very superficial pocket of EU mycetoma. This is a normal bone surface. Patellar surface is smooth, but when it starts to be involved by mycetoma, you can see how irregular, and this is seen on ultrasound. So early bone involvement can be seen on ultrasound scanning. You see, this is a normal one, but you see how this was distracted, and this is fluid, very thick fluid here. Early scalloping of the bone surface this may not be seen on X-ray. So this is an early sign of bone involvement, scalloping, and the presence of the grain near the bone surface or near the periosteum. And you can see here destruction of the periosteum here at the lateral aspect of this image. So this is a superficial pocket, and this is a patellar tendon, and this is lower femoral condyle. You can see this is a cartilage. Okay, so this is a patellar tendon, and you can see a superficial pocket. This can easily be excised without leaving residual grains. This is another one, superficial, and this is a bone surface. It is normal, and we can find here healthy tissues between the pocket and the bone. So this is can be managed surgically. You can see here, this is a real-time scanning of grain movement in EU mycetoma. You can see the mobility of the grains here. You can see freely mobile grains in EU mycetoma during real-time scan. This is only a small part of healthy tissue between the pocket and the bone surface. This is again floating grains. You can see freely mobile grains. So, demonstration of movement is one of the important signs in ultrasound in diagnosing mycetoma. But this is not always can be demonstrated because some grains or pockets can be very compact, so no place for free movement of these grains in many cases. So if demonstrated, this is maybe pathognomonic for the presence of EU mycetomatous grain. This is a superficial pocket in the hand. You notice all previous examples are in the foot or leg or knee, but also we may find affected upper limbs, hands, or and this is an actinomycetoma. So the grains here are big and settle at the bottom of and they are not sharp as EU mycetoma, so, and aggregate with each other to form fungal ball. This is a pocket of grains content, superficial, and this is a bone cavity. You see, this is a bone surface, and inside the bone you can see a bone cavity, form of aggregates of grains here, and you can see destruction of this bone surface forming this cavity. Mycetoma also, we found that it is hypervascular on Doppler ultrasound. So it is very vascular. So when we apply Doppler, you see these are the grains, but it is very rich in blood supply, as you can see in this example. Also very vascular on, and we have a work on this. It is going to be published soon on vascularity of EU mycetoma or mycetoma in general. Doppler differential diagnosis of similar lesions of EU mycetoma. These include foreign body. You can see here a foreign body hyper-reflective with posterior acoustic shadow. So we can see shadow here, but mycetomatous grains has no shadows. This patient have amputated leg, and this was a stump. So this was sent for follow-up, but fortunately we didn't find any grains, residual grains, but we found this stump foreign body. This foreign body may be It is maybe calcified hematoma or residual of stitches forming this granulomatous calcification. Sometimes this is a piece of wood. You can see a linear foreign body. This here also similar to mycetomatous lesion. This may be swelling for a long time. This is neglected foreign body here. And as you can, this may not be radiopaque on X-ray. So we can see this is very superficial. Unfortunately, it is just a piece of, it was just a piece of wood. A thorn, you can see a linear shadow without any surrounding hypoechoic shadow and no grains. Also, this was a thorn. Also, this will not be seen on X-ray because it is radiolucent. This is a loose body in loose foreign body. Again, this was not granulomatous and has posterior acoustic shadow. So no, and this is small cyst, superficial cyst in the sole of the right foot. You can see no grains here. It is echo free, no grains. So this is a simple cyst in the sole. Similar lesion like sebaceous cyst. This sometimes may be as they may be staying for a long time and may be similar to mycetoma, especially in this country. Here there is posterior acoustic enhancement, this brightness. That means there is a cyst here. Okay, so this is very small and it is linked to the dermis, as you can see here, just beneath the dermis, and it was a sebaceous cyst, small sebaceous cyst. This is ganglion cyst. Also, it has echo-free cyst, and you can see a posterior acoustic enhancement, indicating the fluid nature of this cyst, but no grains inside this cavity. And as you can see here, these are the tarsal bones. Baker cyst in the popliteal fossa between semimembranosus tendon and medial head of gastrocnemius muscle. This is a smooth cyst in the popliteal fossa. But sometimes rupture of the cyst. This is the medial head of gastrocnemius muscle, and this is the semimembranosus tendon. But this is a distorted cyst, partially ruptured, also similar to mycetoma. Chronic hematoma of the muscle also may simulate the swelling, forming a swelling also may simulate mycetoma. So no grains here and no posterior acoustic shadow. It was just a chronic hematoma in an old trauma. This was scapular swelling, and it has an fat echo texture, and is well defined. Also posterior acoustic enhancement, but no grains here, and it was excised and found to be lipoma. This is a superficial swelling, lobulated, gently lobulated, and well-defined, thin capsulated, also of fat echo texture. It was also found to be a lipoma, but clinically may be similar to mycetoma swelling. Thickening of the synovial membranes and distension of the versa around the knee. This is a usual finding in arthritis of the knee. So this may be also confused sometimes with, we have to rule mycetoma, especially in the knee, because the joint is very sensitive and excision is very difficult, surgical excision is very difficult around the knee. Also osteophyte formation, but osteophyte, as you can see here, there is a shadow. and this is a quadriceps femoris tendon, and the patella is here, but around the joint we find mycetoma or osteophyte formation in chronic arthritis. This is perianal abscess. You can see thick walled cavity and containing thick fluid. This thick fluid because of hyperreflectivity and containing gas shadows. Here also, this is perianal fistula, also may stand for a long time, sometimes may simulate mycetoma. And also there is a sinus tract here in this perianal abscess. Melanoma, you find swelling, but no grains, and there is a mass with increased vascularity also, but no, without any grains. Neuroma or schwannoma of the median nerve presented with the swelling. As you can see, these dots are cross-sectional in the axons of the median nerve, but there is swelling here just in the sheath of the median nerve in the cross-sectional, but other axons of the median nerve can be seen here. This is in longitudinal scan, you can see the swelling, but no grains. Also, this may be similar to, and it contains blood flow indicating the solid nature of this lesion. In chronic osteomyelitis, this is a normal bone here, and this is a normal bone there, but there is thickening and involucrum of the bone in chronic osteomyelitis. This may be also, and there is a fluid here, just above this involucrum, and this also may simulate mycetoma. Thank you very much.
Thank you, Dr. Mustafa. I think we're going to save questions until the end, so if the next speaker, Dr. El-Shami, could come up, and then we'll take questions at the end of the session. Or are we going live to Saudi? Right, okay, so we're Dr. El-Shami. Very quick changeover. So I'm going to hand over to Dr. El-Shami, who's going to tell us about the use of MRI. Sorry, a consultant.
Okay. Just I would like to let you know, Professor Dr. Mustafa Hishami, he's a consultant radiologist working now currently at Zaytuna specialized hospital here in Khartoum. He did a lot of work on the MRI of mycetoma, and we're going to have a lot of presentation this week.
Bismillahirrahmanirrahim. Mycetoma MRI appearance. MRI is a fairly new technique that has been used since the beginning of 1980. What's this? The principle of MRI scan uses magnetic and radio waves, means that there is no exposure to X-rays or any other damaging forms of radiation. The patient lies inside a large cylinder-shaped magnet, and radio waves from 10 to 30,000 times stronger than the magnetic field of the Earth are sent through the body. This affects the body atoms, forcing the nuclei into a different position. As they move back into their own places, they send out radio waves. The scanner picks these signals, and a computer turns them into a picture. These pictures are based on location and strength of incoming signal. Our body consists mainly of water, and water contains hydrogen atoms. For this reason, the nucleus of hydrogen atom is often used to create an MRI scan. There are no dangerous or side effects connecting to MRI scan. Mycetoma is a localized chronic suppurative infection characterized by exuberant carnation tissue formation involving the skin, subcutaneous tissue, and can extend to involve the deeper tissues. The aim and object of this study is to describe the MRI appearance of mycetoma, with increasing the availability of MRI, especially in endemic areas. This would aid in early diagnosis and facilitate appropriate management. This prospective study was conducted at Mycetoma Research Center, Soba University Hospital, University of Khartoum, in the period between April 2010 and March 2011. The study included 42 patients, 10 female and 32 males. The patient age distribution ranged from 16 to 70 years, and the most common age located between 21 and 30 years. The disease duration ranged from period less than 1 year to more than 13 years, and the most common duration located between 1 to 3 years. The site of disease, either foot, leg, knee, thigh, buttock, forearm, hand, head and neck, and abdominal wall. And the most common site was foot. The MRI finding of mycetoma in skin and subcutaneous tissue, either augmentation of fat tissue planes, abscess formation, sinus tract formation without grains, sinus tract formation with presence of grains. The muscle MRI finding, either no muscle involvement, muscle edema, microabscesses means less than 1 centimeter, macroabscesses more than 1 centimeter. Bone marrow or bone MRI finding, no bone involvement, bone marrow edema, bone cavitation, bone destruction, and the most common pattern is bone marrow edema. MRI mycetoma classification. Mycetoma skin, muscle, bone grading or classifications. For the skin, 1 score means obliteration of skin facial planes. 2 score means abscess formation. Score 3, 4, formation of sinus tract without grains. Score 4 means formation of sinus tract with grains. For the muscle, score 0 means no muscle involvement. Score 1 means muscle edema. Score 2 means formation of microabscesses. Score 3 means formation of macro abscesses more than 1 centimeter. And for bone, score 0 for no bone involvement, score 1 for bone marrow edema, score 2 for bone cavitation, and score 3 for bone destruction. So by adding the score, the lower score is 1 and the higher score is 10. And for the patient, mild disease is for score 1 to 3, and moderate disease is for score 4 to 7, and severe disease is for score 8 to 10. Correlation between MRI mycetoma classification and the size of mycetoma lesion at presentation using chi-square test shows the size of mycetoma lesion at presentation is not indicative for the extent of infiltration. And correlation between MRI mycetoma classification and duration of the mycetoma lesion at presentation using ANOVA test means whether longer or shorter the duration of a mycetoma lesion. This is not indicative for the severity and the extent of disease. Case example number 1. Female patient 39 years old presented by massive anterior abdominal wall, pelvic, thigh, perineum, actinomycetoma for 1 year duration. MRI scan for this patient, coronal T2 weighted image shows diffuse infiltrating lesion extending from subcutaneous plane. The lesion appears of predominant bright signal intensity separated by low signal intensity fibrous matrix. The lesion shows multiple low signal intensity foci within this bright signal intensity carinaceous tissue to assuming dot encircle sign. The lesion appears extending from subcutaneous brain to infiltrate underlying subcutaneous abdominal wall musculatures extending to the perineum and upper thigh, with an evidence of infiltration of underlying bony osseo structures including the right iliac bone and pubic ramus, extending deeply to infiltrate the anterior abdominal wall musculatures and extending deeply to the pelvis, with infiltration of the pelvic musculatures including the psoas muscle, iliacus, and infiltrating the upper thigh musculatures including the adductor groups, with evidence of bone marrow infiltration. And by axial T2 weighted images shows the lesion extending from subcutaneous plane to infiltrate underlying musculatures, pubic bone with an intrapelvic extension. The intrapelvic extension appears displacing the urinary bladder, uterine cervix, and rectum to the left side, with infiltration of right iliac bone. The lesion appears compromising and infiltrating the right vesico-ureteric junction, with consequent right side hydronephrosis. And the T1 weighted image post contrast shows intense enhancement of the lesion with non-enhancing low signal intensity fungal grains. The lesion appears extending caudally to infiltrate the muscle of the upper thigh. And CT scan for this patient shows evidence of bone marrow infiltration with periosteal reaction. and reactive sclerosis. If compared the right iliac bone to the left one, shows evidence of bone periostal reaction and bone marrow sclerosis. The periostal reaction and bone marrow sclerosis involving the right iliac bone and the right ear of the sacrum. Periostal reaction at the right iliac bone, denoting bone marrow infiltration. Case example number 2, male patient 44 years old, presented by foot mycetoma for 1 year duration, and the X-ray shows bone erosive changes involving the base of the first phalanges of the big toe. This is the site of erosion. This is the site of erosion with indistinct cortical outline. And the MRI for the same patient shows a lesion of ill-defined outline extending from the subcutaneous brain. The region shows predominant bright signal intensity with surrounding fibrous matrix and low signal intensity fungal grains, to assuming specific sign, dot encircle sign. The region appears infiltrating the underlying bone with evidence of bone marrow infiltration and bone marrow edema. If compared this bone to adjacent one, shows brightness means bone marrow edema and bone marrow infiltration. And this is the site of infiltration of the bone with specific sign for of mycetoma, dot encircle sign. Center low signal intensity fungal grains surrounded with bright signal intensity crenation tissue, and the outer layer of fibrous matrix, to assuming central dot sign or target sign. This is a central dot sign. And the axial stir images for the same patient shows the extent of infiltration of the lesion from subcutaneous planes. And this is the central dot sign also. Fungal grains in the center, surrounded with bright granulation tissue and outer layer of fibrous matrix. Central dot sign. And the sagittal T1 weighted image shows the region assuming ISO intense signal intensity and extending at the subcutaneous brain to infiltrate underlying tendons and bony osseous structure. Case example number 3, male patient 21 years old, presented by massive frontal skull mycetoma, 7 years duration. MRI coronal T2 weighted image shows a large expansile bony lesion center at the frontal bone of the skull. The lesion assuming predominant low signal intensity with peripheral ISO intense signal rim. The region appears extending to the orbital cavity at left side, displacing the optic nerve and the medial rectus muscle with consequent left side proptosis. The region appears extending to the smooth air cells and the nasal cavity at left side. The region appears or has intracranial extension compromising the underlying frontal lobe with mass effect in terms of midline shift, displacement of interhemispheric fissure to the right side with a deep intracranial extension, and by sagittal T1 weighted image shows the lesion center at the frontal bone. with intracranial extension, displacing the frontal lobe, extending caudally to the sigmoid air cells. The lesion shows iso to bright signal intensity at T1 weighted images. Post-contrast study shows peripheral enhancement of the lesion with non-enhancing low signal intensity fungal mass and associated with evidence of thickening of underlying meningeal layer with enhancement denoting long-standing granulomatous infection. This is enhanced meningeal layer and the peripheral